So this is point to be, just want to highlight this. The second talk is basically on by Dr. SAILESH Kumar. He'll be presenting on poor prognostic markers, OCT based biomarkers in DME and AMD.
Good morning, all. Thank you, Anubhav sir, for the invite. I'll be presenting on OCT biomarkers in DME, poor prognostic OCT biomarkers in DME and AMD. Diabetic macular edema, as we all know, is one of the most common cases that we come across in our retina clinics. About 30% of individuals with over 20 years of diabetes can develop diabetic macular edema. It requires multiple intraretinal injections, which is invasive, and so there is a heavy burden on the patient as well as the physician. There are no reliable methods to determine which individuals with DME would gain or lose vision over time. So, what are biomarkers? A biomarker refers to a broad subcategory of medical science that objectively indicates the state of health and well-being of an individual. So these can be anatomical, biochemical, molecular parameters, or imaging features. It'll be useful in diagnosis, disease progression, or predicting and monitoring effects of therapeutic interventions. So OCT, as we all know, with the advancements in the technology, it's like an optical biopsy. It's a very useful biomarker which can predict visual outcome in these cases. Diabetic macular edema can be either tractional or non-tractional. For tractional, surgery might be the treatment of choice. For non-tractional edema, like spongiform, cystoid macular edema, or neurosensory detachment, these require medical treatment with lasers and injections. So, but classifying into these subtypes alone cannot actually prognosticate the diabetic macular edema. So we have these OCT biomarkers in DME. Many biomarkers are described, most common of which are central subfield thickness, drill, which is disorganization of retinal inner layers, hyperreflective foci, integrity of the ELM and ellipsoid zone, cholesterol crystals and hyperreflective crystalline deposits, intracystic hyperreflective material, bridging retinal processes, and biomarkers in choroid like hyperreflective foci in choroid and choroidal thickness. Central macular thickness is the most commonly used biomarker to diagnose, to take a treatment decision, and to see the follow-up. But CMT alone cannot be used as a reliable biomarker to predict visual outcome. So, which are the biomarkers which contribute to poor visual prognosis or poor prognostic biomarkers? Mainly, the most important is drill, that is disorganization of retinal inner layers, then ELM discontinuity, ellipsoid zone discontinuity, cholesterol crystals or hyperreflective crystalline deposits, and hyperreflective foci on choroid. So, these are the biomarkers in DME which carries a poor visual prognosis. First of all, about drill. Drill is the inability to differentiate between the GCL-IPL complex, inner nuclear layer, and outer plexiform layer. It's the loss of boundaries between the layers of the retina. See here in this picture, you can see that the inner retinal layers so how to find drill? To find drill, you can come from outside the central macula, find the delineation between the inner retinal layers where the health of the retina is preserved, and follow the intact interfaces towards fovea. Point is. So here you can see that the delineation between the inner retinal layers are lost perifoveally. So if the segmentation zones are present all the way to fovea, there is no drill. If it breaks down and the borders could not be traced till fovea, then drill is present, this much area. So drill affecting at least 50% or 500 microns of the 1 mm central retinal zone was associated with poor visual outcome. Presence of drill causes mild to moderate visual impairment, not severe visual impairment. Disorganization of or destruction of cells within inner retinal layers, including bipolar, amacrine, or horizontal cells. It possibly indicates a disruption of pathways that transmit visual information from the photoreceptors to the ganglion cells. The vessels of the deep capillary plexus supply these layers, and the loss of these capillaries damages these structures. Therefore, the presence of drill correlates with the capillary flow void regions on octa and macular ischemia on FFA. This is the corresponding octa picture of this OCT with the area of drill corresponding to the foveal avascular zone. Next is integrity of the external limiting membrane. External limiting membrane is the plexus between the Muller cells and the photoreceptors. It forms the third blood retinal barrier. When disrupted, fluid goes into the outer retina and it presents as neurosensory detachment. So ELM status is closely related to visual acuity, as is the ISOS junction status in DME. It's useful in the evaluation of prognosis for the treatment. And then integrity of the ellipsoid zone. ELM is this hyperreflective membrane. This is the RPE, and just above the RPE, this hyperreflective membrane is the ellipsoid zone, and above the ellipsoid zone is the external limiting membrane. So in chronic cases of DME, this external limiting membrane loss occurs first, and the disruption in external limiting membrane can lead to fluid seeping beneath the subretinal space. So here you can see external limiting membrane is lost in this case. There is a patchy loss subfoveally. Here in this case, you can see there is an extensive loss at the fovea. Both ELM and ellipsoid zone are lost. So these carry a poor visual prognosis. Percentage of disruption is a significant predictor of visual acuity in patients with DME. And then there are bridging retinal processes, which are vertically oriented hyperreflective lines between the cystic cavities. They represent residual neural elements that connect the outer and inner retina, thereby facilitating the transmission of visual impulses. Absence of these bridging retinal processes have poor prognosis post-treatment. Here you can see there is a large foveal cystoid. There are some bridging retinal processes here. If these bridging retinal processes are absent, that means if there is a large foveal cystoid, large giant cystoid, that indicates a poor treatment response, and it carry a poor visual prognosis. Even if you inject in these cases, these can eventually result in foveal atrophy, and there may not be any improvement in vision. Then another one is cholesterol crystals or hyperreflective crystalline deposits. On OCT, hyperreflective crystalline deposits or cholesterol crystals appear as single or multiple linear hyperreflective lines of high intensity on or above the RPE without posterior shadowing. On ophthalmoscopy and color fundus photography, HCDs are identified as brilliantly yellow-white or golden yellow lesions. So these are distinct from the commonly observed hard exudates, which appear as yellow flecks in the retinal arcades of DR patients. Plaques of hard exudates are typically seen in circinate pattern peripheral to the area of leakage. These are horizontal and planar. They can be single or multi-layered. They represent intraretinal or subretinal cholesterol crystal deposits. It can indicate chronic vascular leakage, hypocholesterolemia, requiring lipid-lowering medication. Involvement of the fovea can cause severe visual impairment. So can I carry on? OCT biomarkers in
Finish it up
AMD.
fast, please.
In AMD, we know that there is RPE detachment, there can be subretinal fluid and intraretinal fluid. Out of this, the most important poor prognostic marker is intraretinal fluid. It carries a poor visual prognosis, poor response to treatment, and poor visual acuity at initial presentation. And also photoreceptor layer integrity, as we have already mentioned in DME, the photoreceptor degeneration and loss are well-known features in AMD and are considered key factors of visual decrease in this disease. There is one outer retinal tubulations which Sir has shown. They characteristically develop in advanced stages of AMD and are associated with the presence of macular neovascularization and geographic atrophy. You can see these outer retinal tubulations as these cylindrical structures with hyperreflective borders. So they can be considered as a rearrangement of photoreceptors as a consequence of injury, and their presence has been associated with worse visual prognosis. Then there is subretinal hyperrefractive material, which is also an indicator of poor prognosis. It is common and often persists after anti-VEGF treatment. It may not resolve even after anti-VEGF treatment. It could be made up of fluid, fibrin, blood, scar, and neovascularization, even though it could change over time. So the take-home message is OCT is a good imaging biomarker. CMT was regularly believed was used in all studies, but it has only modest correlation with visual acuity. Drill, photoreceptor layer integrity, hyperrefractive foci, and intraretinal fluid are robust predictors of visual acuity. OCT biomarkers help in diagnosis, grade the severity of the disease, and modify our treatment regimen and predict prognosis in DME and AMD. Thank you, sir.
Thank you, Dr. Sailesh. These biomarkers are important basically to understand, because if they are present, it's difficult to treat the patient, not in terms of treatment response, but in terms of visual acuity improvement. Even if there is a presence of thickening, macular thickening or edema, patient might respond in terms of macular edema resolution, but vision might not improve a lot. So we have to understand these biomarkers. If they are present, we should not run behind drying the macula in all edema cases. Or if the wet AMD is there, we have to understand that vision improvement might not be there in long run. Thank you. Next, I'll be presenting on